Now I request Dr. Shashi Mawar to kindly address the audience.
A very good morning, everyone. Respected Director Sir, Dr. Kuleria, Dr. Sanjay Agarwal, Professor and Head Department of Nephrology, Dr. Lata Venkateshan, Principal College of Nursing, my colleagues, and dear participants as well as students. Kidney Day celebration started somewhere in 2006, and since then, more and more attention has been given to kidney health. So this year, the theme is bridge the knowledge gap for healthcare providers, for general public as well as for the stakeholders. So since the burden of kidney diseases is increasing rapidly, we need to empower the healthcare providers and specifically the workforce of the nursing who contribute a major part or a major chunk in the healthcare services among those people who are at risk for developing kidney diseases. The webinar is organized with the objectives to increase the awareness regarding the amazing kidneys. It is to encourage the systemic screening of all the patients with diabetes and hypertension for CKD, as well as to encourage preventive behaviors. It is to educate all nursing professionals about their role in detecting and reducing the risk of kidney diseases, particularly in the high-risk population. On World Kidney Day, we are calling on everyone to check if they are at risk for kidney diseases and encouraging people with any risk and risk factors to take a special kidney function test. I welcome all the participants who are present online and offline for this program. Happy learning to all of you and hope you will enjoy these few hours of learning. Thank you.
Thank you, ma'am. Now I request Now I request Dr. Randeep Guleria, Director, AIIMS New Delhi, to please address the audience.
Good morning. Dr. Sanjay Agarwal, Head Department of Nephrology, Dr. Lata Venkatesh, Principal College of Nursing, Dr. Shashi Mawar, other faculty from the College of Nursing, students, delegates, ladies and gentlemen. First of all, greetings on World Kidney Day. I think this is an important day because it reinforces our commitment towards protection and prevention of kidney diseases. The theme of this year's World Kidney Day is bridging the knowledge gap, and I think this is very important because there are a number of knowledge gaps in all sections of society, among doctors, among healthcare workers, and among the general public. Very often, kidney diseases are taken lightly. People don't understand the implication, the long-term implication of kidney diseases and why they should act early rather than late. As has already been said, there's also data which suggests that kidney diseases are rising globally and especially in the developing world. That's true for our country. It is driven by many factors, including other diseases like hypertension and diabetes, but a lot of effort needs to be put forward to prevent them or to prevent their progression. So even if someone has early kidney disease, it's very important that he is aware of what are the do's and don'ts so that it does not progress to what we call end-stage renal disease, which leads to issues of dialysis and transplantation. So I think it's very important for all of us as healthcare workers, and especially the nursing community, to come forward and see how they can increase awareness among the public and among their colleagues as far as kidney diseases are concerned. So I'm very happy that this program is being organized. You're having a number of speakers who will talk on these issues. And then we've also organized poster competitions, Nukkad Natak and all. So I think these all activities are very important because they help in connecting with the general public and making them aware in other, I would say, subtle and, let's say, user-friendly manners as to the importance and the issues as far as kidney disease are concerned. I'd like to take this opportunity to wish you all the best, and I'm sure this will be a very fruitful session. So thank you very much for inviting me and all the best. Thank you.
Thank you, sir, for your inspirational words. Now I invite Dr. Sanjay Agarwal, Professor, Head Department of Nephrology, to address the audience.
Good morning, everybody. Professor Randeep Guleria, Director, All India Institute of Medical Sciences, Dr. Shashi Mawar, and other faculty of the College of Nursing. I will give you a perspective of chronic kidney disease. As compared to other non-communicable disease, chronic kidney disease is not given as much importance in the community, not only in India, but across the world also. If you see the common causes of death in the society, then 15 years back, chronic kidney disease was 12th common cause of death. Now, currently it is 8th common cause of death, and the estimation is that in 2040 it will be somewhere 4th or 5th common cause of death. Now, this number is further important if you see that the capture of cause of death in the society, in the hospital. If a patient of chronic kidney disease dies of cardiovascular complication, chronic kidney disease is never captured as a cause of death. The cause of death will still be captured as the cardiovascular complication. So these estimation of whether 12th common cause or 8th common cause is in spite of having these deficiency of proper capturing of causes of death. Now if you come to the prevalence of chronic kidney disease in India, there is a study called Global Burden of Disease India chapter, and that has shown from 1990 the prevalence was 5.4 in whole country, and in 2019 it has increased from 5.4 to 9.1, and with time we are expecting that it is going to increase further. If you see the end stage of chronic kidney disease, although there are national transplant program and national dialysis program, both peritoneal as well as hemodialysis, is still a very small component of patients who actually need these therapy actually are getting a regular therapy in our country. So now then we come back that we need to prevent the chronic kidney disease, and that is why the World Kidney Day from 2006 is being organized across the world, with increasing the knowledge to the public, policy maker and a medical professional of all types, so that it needs to be prevented. Once it develops, then even best of the countries are not able to give the treatment to all the patients who actually need it. So with that aim, the current today's organization of this event from College of Nursing is a very important step, because nursing forms a very backbone of the hospital and can be source of spread of information to admitted patient as well as to their family members. So from that angle, you have got a very important work, important thing to do in the society for prevention of chronic kidney disease. With these few words, I again welcome you and hope that the deliberation will be helpful and you will be able to carry the message of prevention of chronic kidney disease in the society. Thank you very much.
Thank you, sir, for enlightening us on CKD. Now I invite Dr. Pragya Pathak to deliver the vote of thanks.
Very good morning to the dignitaries on the dais, the participants, and all those who have joined us for this ceremony of World Kidney Day 2022. It gives me immense pleasure to propose this vote of thanks on behalf of Chairperson, Coordinator, and organizing team of today's World Kidney Day program. I would like to express my sincere thanks to our most distinguished chief guest of the day, Professor Dr. Randeep Guleria, Director, AIIMS, Delhi, for gracing this occasion with his esteemed presence and always supporting us, sir. Thank you, sir, for your thought-provoking address. I would like to express profound thanks to the esteemed guest, Dr. S.K. Agrawal, Head Department of Nephrology, AIIMS, for his support and words of wisdom. I extend my sincere gratitude to Dr. Lata Venkatesan, Principal, College of Nursing, in her absentia for her unconditional support, encouragement, and
A decrease GFR of less than 60 ml per minute per 1.73 meter square. Along with that, albuminuria of at least 30 mg for every 24 hours or the presence of kidney markers like hematuria or structural damage like polycystic kidney disease, which are present for at least 3 months. The global prevalence is approximately 10% of found to be more prevalent in low income and middle income countries. According to KDIGO guidelines, CKD is classified into 5 stages depending upon the GFR level. So stage 1, 2 is the GFR levels more than 90 and between 60 to 89 respectively, with moderate stage or moderate CKD is ranging between 45 to 44, whereas severe CKD or severe disease is that is your stage 4 between 15 to 29, and the end stage is when the GFR falls less than 15 ml per minute per 1.73 meter square. So how does the patient present? Usually the patients come up, they have asymptomatic or CKD is incidental pickup while routine screening. Usually the patients are asymptomatic between stages 1, 2 and 3. Otherwise, the patient comes up for a routine checkup, and then we pick up when we do their screening test, we find that there is something wrong with the kidneys. Along with that, less commonly the patient presents with gross hematuria, foamy urine because albumin is being leaked. Then patient will have nocturia, flank pain and decreased urine output because your GFR is also decreasing. In advanced stage, like in stage 4 and 5, the patient will definitely present with fatigue, poor appetite, nausea, vomiting, some metallic taste because uremia is also developing. There is unintentional weight loss associated with loss of appetite, pruritus again associated with your uremia, changes in mental status, dyspnea and peripheral edema. And the risk-based approach should always be undertaken, particularly for people who are older than 60 or those who have a history of diabetes or hypertension, or those who have risk factors associated like autoimmune disease, obesity, renal calculi, UTI, or they have been exposed to certain toxins like NSAIDs, lithium, etc. So overall the risk factors, the most important top 2 are diabetes and hypertension. Along with that, the third one is glomerulonephritis, infection, environmental exposure to air pollution, herbal remedies. Most of the time patients come up over here that they have been exposed or they have taken some herbal medicines for some or the other reasons, a risk factor for people with low income and low education. Other leading causes of CKD are again obstructed urine outflow. This is other than diabetes and hypertension, which again is the most important leading cause. Then renal artery stenosis, fetal development problems, SLE, malaria, yellow fever. These are some of the leading causes of CKD. So how do we diagnose it? First and foremost, check the vitals, blood pressure most importantly, because these patients, if they do not have hypertension, they may develop hypertension, and if they do have predisposing hypertension, then CKD should always be screened. Along with that, CBC with ESR, biochemical profile, which includes our renal perfusion test, renal function test, serum urea creatinine, electrolytes, potassium in particular, phosphate. Then urine analysis, which should include urine protein creatinine ratio, albumin levels, then urine culture and certain images like ultrasound and radiograph can be done. So these are the diagnostic investigations. In ultrasound, we can see whether there is any hypertrophy, whether there is any segmental changes. We can always rule out the presence of cyst. We can always rule out renal artery stenosis, which decreases the number of functioning nephrons. So whatever nephrons are present, they overwork their hypertrophy to compensate for the loss, and over the time, intraglomerular hypertension develops. Along with that, there is angiotensin and RAS system activated, which also enhances the progression of CKD. Eventually, because of high intraglomerular capillary pressure, the size of selective function of glomerular permeability is damaged, which increases the urinary excretion of albumin and proteins. So the net effect is patient will develop hypertension, there will be increased vascular volume, ultimately causing heart failure. Because urine is not being filtered, we will have hyperkalemia. Then elimination of nitrogenous waste will, the decrease in that will cause uremia. Subsequently, with the loss of kidney function, there are chances that the patient will develop anemia, acidosis, hypocalcemia, and hyperparathyroidism. All of these will cause impaired immune function, skin disorders, GI manifestations, neurological symptoms, and sexual dysfunction. So what I want to tell is, though the changes take, like the GFR is lost for more than 1 ml per minute per year, but if you add these small losses every year, it will not take much time for the patient to progress directly into ESRD, that is your stage 5. So what happens at the end? The patient complicates into conditions of fluid retention, hyperkalemia, there will be cardiovascular disease, hypocalcemia will lead to weak bones, patient will develop anemia, decreased sexual drive, damage to CNS, decreased immune response, and pregnancy related complications will be there. So now we know what are the symptoms and how they will be affected. So we look for the management. The management is basically divided into 3 aspects: medical, surgical, and renal replacement therapy. These are the 10 key points to manage the kidney function. First and foremost is keeping the blood sugar and blood pressure under control. We have the guidelines and I'm going to talk about it. Working with the healthcare team to monitor the kidney function, regular test follow-up, taking only the prescribed medicines and avoiding the over-the-counter drugs, working up with the dietitian to develop a meal plan, ensuring the activity, some sort of physical activity as part of your routine, aim for a healthy weight, get adequate sleep, stop smoking, and find healthy ways to cope with stress and depression, because they all contribute to kidney disease. So the treatment objective is to detect CKD early in high-risk population, control hypertension, manage blood glucose levels, treat the underlying causes if at all we are able to pick them up, and prevent further complications. And what are we targeting? We are targeting to monitor and treat the biochemical abnormalities which have actually developed as a consequence of CKD, like anemia, metabolic acidosis, mineral metabolism, dyslipidemia, and nutrition. So we'll see one by one. For hypertension, our target has to be to maintain a BP of less than 130 by 80 mmHg, and if the patient has proteinuria, then our target should be that the patient should have a BP of less than 125 by 75 mmHg. For this, the patients are usually kept on a combination of drugs, ACE inhibitors or ARBs, along with diuretics and calcium channel blockers, because individually these drugs can be more lethal for the kidneys. For diabetes and glycemic control, the target should be less than or approximately 7.0%, because with improved glycemic control, it reduces the rate at which the albumin will be released in the urine. And risk of hypoglycemia also increases as kidney function becomes impaired. Then coming to dyslipidemia, abnormality, the presence of high LDL in the blood actually will add to CVDs. So our target should be somewhere around preventing the occurrence of cardiovascular disease. For proteinuria, our target should be somewhere between less than 30 mg for 24 hours. If the patient have nephrotic syndrome, then somewhere around 3 gram per 24 hours. So that this we need to know so that we can regulate the diet of the patients. For treating anemia, usually the patients are put on epoetin alpha. For the patients who are undergoing hemodialysis, the doses are 50 to 100 mics per kg IV or sub-Q 3 times a week, and for non-hemodialytic patients, 10,000 units every week. Then for the doses of darbepoetin alpha, for dialysis patients, 0.45 micrograms per kg IV or sub-Q every week, and for non-dialysis patient, 60 mics sub-Q every 2 weeks. Then for the loss of calcium and phosphate metabolism abnormalities, we should target that 14 to 16%, we should target to preserve these and give calcium supplements, at the same time prevent the accumulation of phosphate in the body. For treating hyperkalemia, most of these patients will have a potassium level somewhere around 5 to 6, and we have to take care of that, which we can do through dietary modification, like removing the food products like dried fruits, nuts, deep colored green leafy vegetables, juices, milk and yogurt, limiting their amount in their diet, so that we are trying to control the increase in potassium levels. Other than that, we can also put the patient on diuretics, but make sure that the patient is not on potassium sparing diuretics, because this is going to add on potassium levels. Maybe stop or reduce beta blockers, ACE inhibitors and ARBs, because they have a correlation that they tend to increase potassium levels. For nutrition, one has to think about that the patient is always in a catabolic state, patient is anorexic, so we have to consult with a renal dietitian. We have to give extra calories to the patient, because they also have fatigue. So our target should be that the patient should have minimum 35 kilocalories per kg per day for less than 60 years, and between 30 to 35 kilocalories per kg per day for more than 60 years of age. And to increase that, we can add little extra non-saturated oils, some bread, crackers, not particularly that should not contain carbohydrates, cooked vegetables, add extra salad dressing, add non-protein calorie supplement to the diet. Then coming to protein intake, for stages 1 to 3, it is recommended that we should have at least 0.75 grams per kg per day. So that can be given through half cup of milk. Again, we have to make sure that we can always give extra protein, because the patient is losing protein from his body. But at the same time, we should not give more of fluid. So half cup of milk is good enough for the patient. Along with that, adding egg or just egg white. If the patient is non-vegetarian, yes, we can give 3 meals, 3 servings in a day. For stages 4 to 5, with the patient not being on dialysis, protein intake should be around 0.6 gram per kg per day. Along with that, the total the food components that can be included should be vegetables, meat in small frequency, like 5 to 6 servings of meals the patient should be offered. For patients who are already on stage 5 on dialysis, the protein intake should be increased as much as to 1.2 to 1.3 grams per kg per day, and the patient should receive at least 10 to 11 servings of meals. At any point of time, one should not hesitate from adding more of protein. When it comes to fluid is a strict no-no. We have to estimate, fluid intake is basically estimated on the amount of urine output. So previous day urine output plus, in some guidelines it says 600 ml, or in some 1000 ml. 1000 ml is your the hidden loss from the body. So if we give extra fluid, sometimes the patient, they take in the hidden fluids like soup, tea, etc. So we have to educate, and we have to tell the patient not to take any extra fluid, and they have to have an estimation. Here comes our role, that we have to tell them to keep a track of the urine output, disease state, and what is the treatment modality they are on. If they are on dialysis, again we have to make sure that we should not overburden them. So what happens if the patient comes up with the complaints that I am thirsty and I want to drink more fluid, I have to have water? What we can tell them, to keep their mouth clean, keep rinsing their mouth. You can give ice chips. If the patient is non-diabetic, again non-sweetened candies can be given. You can suggest the patient to chew gum and try lemon wedges. These are actually quite practical, available in our setup, and can be given. And we can also tell the patient to have only measured water in their bottles and carry at all times, because again dehydration has to be avoided. The other therapies which are useful in management of CKD are dialysis, the 2 types, hemodialysis and peritoneal dialysis. And finally, if the patient can undergo renal transplant, 2 types, cadaver and living. That is the ultimate choice of treatment for CKD. The non-pharmacological treatment includes maintaining water and electrolyte balance, maintaining strict IO chart. So whenever you have a patient with this, you have to tell them all these things. Maintain your electrolyte balance. Do not dehydrate yourself or overhydrate. Maintain a intake output chart. Weigh yourself daily. And if the patient has got any other habits like smoking, tobacco, then one should be motivated to stop those habits. Then encourage the patient to maintain daily exercise as tolerated, because that would help the patient to overcome the fatigue, and of course avoid nephrotoxins like herbal medications and NSAIDs. So this was all about my talk. Hope you have gained some knowledge. Thank you.
Thank you, Anubha, for enlightening us with the overview of CKD. And she has very well highlighted about the management, the dietary specifications, etc. And now I request Aditi to give a token of love to her. Photo. सामने जाओ तो नीला हटा के देंगे Now it is a time for tea break. All of you can join us in the pantry for tea break.
वो सारी चीजें ये बैठी बस ये आपका कैमरा दिखेगा से डोंट अलाउ इनने ऑडियो ऑन तक ये ऑडियो
सर बुला रहे हैं कौन शर्मा सर बुला रहे हैं बोल रहे हैं कि वो अभी वो प्रेजेंटेशन लोड कर रहे हैं सुन के तो आ जाओ वो बुला रहे हैं ना आप कहते वही वहाँ पे मैं कर रहा हूँ क्या कर रहे हैं जो बोला किसी के लिए
वाला होता है और हम तो है ना नाइट इवेंट हो रहे हैं वो टीचर बनते हैं ठीक है
कुछ नहीं बता रहा मैं इसको
हाँ ना राम कसम मैंने मेरे बारे में नहीं बताया।
नहीं मैंने कुछ नहीं बोला हाँ? आप तो ऐसा कह रहे हो क्योंकि चलो
तेरे को मैं अभी सुन नहीं बड़े भाई नहीं है
का फोन आ गया तो मैं बाथरूम करके मैं सुनिए सबके सामने अब मिल
कल देखे मैंने सिस्टमेटिक से मैं काम दिल से करना चाहता हूँ, ठीक है।
सर मैं आपके साथ नहीं था
साथ मतलब मेरे को बोल के जाता कि मैं वहाँ जा रहा हूँ।
बाथरूम उतरे ही गया मैं एक कॉल आ गई बड़ी बहन की बस वो हमें सुनने लगे
मेरा ना मेरी फैमिली गाँव में है।
सुनता है
सुन मम्मी है पापा है जब भी फोन आता है ना मैं बोलता हूँ बाद में बात करना। चाय पी
चाय
मैं ना पी रहा था मेरे को शुगर
क्या हुआ सुनो
कल से मैं बता रहा था ना सेफ गया था आईपी के लिए। डॉक्टर शरीफ ने खुद बोला है कि आईपी चेंज करो। पेशेंट को बोला हाँ बोला नहीं जो आईपी है उसी से चला। मैंने उनको बार बार बोला हूँ इसमें स्ट्रीमिंग के दौरान ये दिक्कत करता है। स्विच के लिए इन्होंने सीएफ ने रिकमेंड किया एक अच्छा सा स्विच लो स्टूडियो के लिए। पंकज को लेटर बना के इसको दिया। इसको जब बोलता हूँ ये कह रहे तुम बात करो। पंकज
पीछे आ गया था तू बता रहा था स्विच किया कोई चीज तो फिर ये इसने वो किया नहीं कि
इसने कुछ नहीं रोक दिया। बोला कि स्विच है नहीं तुम मुझसे बात करो पंकज से मैं बात करता हूँ कार्ड पे डालता हूँ घुमाता रहता है। जब इवेंट तो बुकिंग लेते हो यूट्यूब स्ट्रीमिंग सारे कैंडिडेट वेट कर रहे हैं लाइव नहीं चल रहा है ना ये जस्ट हाँ डायरेक्ट ले लिया। अरे नहीं आप मैं ध्यान रखता हूँ मैं इसको बोला है। और सुरेंद्र क्या करता है ना लेडीज के बीच में बैठ के फोटो खींचता है कुछ करने वाला नहीं। इसको बोला मैंने यहीं पे रुकना है मैं अकेले मैं इसको बोला ये पीसी तू देखियो
इसको मेरी एक बात ध्यान से सुन इस बंदे को चेंज कर
कौन है यहाँ पे
कुलवंत का जैसे
कुलवंत को इतना आप हल्के से मत लो। मैं आपको भी
तू ही कह रहा है मुझे तो नहीं पता फिर यार मैं जब
कुलवंत अभी
रिकमेंड नहीं किया तूने किया
सुनो ना कुलवंत अभी आया है
मुझे नहीं
आया ना इस बंदे के ऊपर कैसे भरोसा करो।
नहीं वो करेगा जब पैसे मिलेंगे आएगा
पैसे की बात नहीं है कल बात हो रही है तुम 9:30 बजे इवेंट आ रहे हो।
अच्छा बोला उसे
कल खुद बोला 8:30 बजे आओ। मैं देखो भैया उसके ऊपर ड्यूटी के दौरान उसके ऊपर कोई भरोसा
नहीं वो तेरे को देखना मैं तो ये कहता हूँ मेरी बात समझ ये सिखाना कोई रॉकेट साइंस नहीं है 4 चीज़ें समझ मेरी बात को जो नहीं है उसको समझ नहीं आता बाहर जाएगा अपने आप समझ आ जाएगा समझ रहा है मेरी बात को बंदा बदल
कौन है
आएगा कौन है
यहाँ पे एक तो इसमें लगी है यहाँ पे जो स्टाफ है मैं उसी को तो बोलूँगा।
नहीं यहाँ तू बोलेगा ये ऐसे चेंज करके दे दो मेरे को कोई नया नहीं
नीचे जो बैठा है ना मेरी बात आप मेरी जगह पे आ जाओ हाँ बोलो तब तो समझ ये कहता है कि इसकी वजह मैं आप जो कहते हो मेरे को देखो सुबह से लेकर कितना बढ़िया मैं इवेंट कर रहा हूँ जस्ट यहाँ बैठ जा थोड़ी सी मतलब वहाँ चला जा वो
है इसे नहीं है
इसको चाहिए
वो भी है दूसरा है ये चाहता है बहन मेरी उठा के रखे है क्या चीज़ है ये ऐसे थोड़ी ना होता है।
और वो वक्त भी आया अभी आया मिलता हुआ और फिर आधा घंटे के बाद एक भयंकर हंसी दी
करके अपना दिमाग
क्या दिमाग
करना
में यार
सिर्फ ये
क्या इवेंट में इसको अभी आया क्या हो क्या हो नहीं चल रहा इसको कुछ समझ में नहीं आ रहा है इसको ना कुछ और वो ये बैठा है हुसैन को बुला दो मैंने बोला उसको बोल जो जरूरत है मेरे को फोन कर
ये आ गए मेरे को
मैं बिजी अभी तो बोला बाहर हुसैन को बोला उसको बता देना मैं बिजी
क्वेश्चन करके मैं सिर्फ ये कहता हूँ छोटे भाई होने के के अपना दिमाग को खराब
दिमाग की
करें।
बात नहीं है, एथिक्स चाहिए ना। आपका क्या
मेरे को बता दें, मैं
नहीं, एक बार
मैं आप सारे
एक बात
बता दें, मैं कर
जॉब रोल ना, जॉब रोल सबका अलग अलग है। तेरा जो जॉब रोल है असिस्टेंट चाहिए, उसको पता है, पता है, इसको खाली खाने में और पैकिंग में मतलब है, और नीचे वाला बंदा इसको खाली गुस्सा आता है, ये वाला बॉस, और बाकी उसको खाली गुस्सा आता है, नीचे सुन तो पहले कब तू शर्मा जी मैं बोला पंकज सर मैं नहीं करूँगा, तुम करो। आगे से बता दूंगा, यूट्यूब में नहीं, यहाँ पे आज के जो लेसन हुआ यूट्यूब में नहीं कर सकते, नेटवर्क इशू।
पहले बता दें, जैसे बुकिंग आए उसको उसी टाइम फोन कर दे। हाँ,
यूट्यूब नहीं चलेगा और बाकी हो सकता है, जो चीज़ नहीं है तो नहीं है।
मैं तो सिर्फ ये कहता हूँ, अगर टेंशन
चलिए
चलो ठीक है।
मैं हूँ ना आपके साथ, मैं भी पीऊँगा ना।
अब कंटिन्यू आ रहा है।
अरे मैं क्यों?
एसिडिटी कितना
हम स्टार्ट करें 10
Welcome back after the tea session. Now I would like to invite Dr. Sandeep Mahajan, Professor from the Department of Nephrology, Sir has a long, exhaustive list of accomplishment, and it is definitely going to be an enriching experience. So, sir, I would like to invite you for your talk on optimizing kidney function.
Well, good morning, one and all, and it's quite appropriate that at the World Kidney Day we are talking about optimizing kidney function because kidneys. Oh, yeah. नहीं डन। अच्छा, mouse ज़्यादा करना। So, because kidneys, besides being leading on important cause for chronic kidney disease, is also an important reason for so many other comorbidities. So, as we have been discussing since morning, kidney disease is a major health problem, and as I just highlighted, chronic kidney disease, besides just kidney failure, leads on to various morbidities like cardiovascular as well as stroke, which carry huge social and economic burden. And once we are at a stage of dialysis and transplant, the kidney failure becomes expensive and difficult to treat. And therefore, optimizing renal function and reducing progression of chronic kidney disease has both important clinical and economic outcomes. So what I would be doing in this 15 or 20 minutes would be try to impress upon the reasons of increasing incidence of chronic kidney disease, especially in India, which actually is template for most of the developing world. How chronic kidney disease affords opportunities for intervention, both at the primary, secondary, and the tertiary level. And since hypertension and diabetes are the commonest causes for chronic kidney disease worldwide, just a brief overview how to manage hypertension and diabetes in patients with chronic kidney disease. So, what have been the reasons for off-late so-called surge or epidemic of chronic kidney disease in all over the world, particularly the developing countries like India? A lot has to do with the unhealthy lifestyle due to rapid urbanization and an unplanned infrastructure. There is also an increasing burden of non-communicable diseases, particularly diabetes and hypertension. In fact, India very shortly might become the diabetic capital of the world in another decade or so. More importantly, we have very poor awareness about chronic kidney disease among the general public and even among the medical fraternity. We have inadequate management of predisposing diseases like diabetes, hypertension, and obesity. And we rarely have any knowledge about the putative or causative factors for chronic kidney disease, of which unsupervised medicine intake of various formulations is an important cause. Also, most of the developing world has poor recognition and recording of chronic kidney disease data, and therefore we have very little data to go with. Besides, we have very limited nephrologists, and wherever nephrologists are, they are actually more dense in a particular pocket, which is urban, and therefore we have a very poor nephrologist to patient ratio in majority of our districts in our country. And the biggest problem again is that we have limited healthcare facilities and infrastructure to work with. Chronic kidney disease fortunately gives us enough opportunity of interventions. In fact, if we look at all the patients who suffer from chronic kidney disease, a good 80 to 90%, if detected early, would be early stages of chronic kidney disease. That is, once their renal function or GFR is more than 60. And if we detect these patients early, we have multiple interventions which can slow the progression of these patients to advanced stages. And therefore, this affords us opportunities for optimizing renal function. And this we can do by raising the awareness, which is the theme of the World Kidney Day this time, detecting chronic kidney disease, and minimizing the progression and, more importantly, the complications of chronic kidney disease. So we are not only talking about the progression to chronic kidney disease to end stage kidney disease, but also the other comorbidities, including the cardiovascular and metabolic complications. So, we all know that primary prevention is perhaps the best and the most cost effective method of preventing any disease. We know that approximately one-third diabetics and one-third hypertensives are likely to develop chronic kidney disease. However, unfortunately, majority of these patients who are diabetic and hypertensive hardly know about this association. So most of them would be willfully unaware that one, they have a problem, and secondly, this problem is major enough that it can lead on to significant chronic kidney disease subsequently. And it's not only the general public, even the general practitioners and other super specialists are not sensitized enough to these associations. So many times we have patients who have been seeing a physician, who have been seeing a practitioner, but they have not even got a single urine routine report with them. They might have repeated HbA1cs, they might have lipid profiles, but nobody has bothered to look at their kidney functions or even a simple urine routine test in all their follow-up. So even the general practitioners have poor awareness about chronic kidney disease and methods to prevent its progression. So once chronic kidney disease is there, then it's better to detect it early, and that is what we call it as a secondary prevention. And it is important to realize that chronic kidney disease is predominantly asymptomatic. You don't have any symptoms which are relatable actually to your kidney failure. And therefore, early detection is predominantly if you screen these patients, and if you detect these cases early, that's where you would have maximum benefit of intervening both in slowing the progression and preventing the comorbidities of chronic kidney disease. Ideally, all adult population should be screened for chronic kidney disease, but this obviously is difficult even with the best of infrastructures. And therefore, all the patients who actually are at a higher risk, whether they are more than 65 years old, whether they have family history or they themselves have diabetes and hypertension, whether they have history of chronic kidney disease, or who have suffered from any renal damage previously and have been abusing any sorts of medications for a long time. So even if we concentrate among these high-risk population, we would have the most efficient approach of screening these patients for chronic kidney disease. And the least effective, but unfortunately the most common intervention which we all follow as nephrologists and as physicians is the tertiary prevention. That is, once the chronic kidney disease has already set in to a significant degree and we can't do much to either halt or reverse the progression of chronic kidney disease. So what we can do in these stages? The most important thing is the patient counseling and lifestyle modifications. These simple things which cost nothing are actually overlooked, and these are the most important factors or most important pillars in managing the patients with established chronic kidney disease. The most important problem is we all know the association of smoking and tobacco with cancer, with cardiovascular diseases, with stroke. But we often forget that tobacco is equally poisonous for the kidneys and kidney disease progression. So any patient who has chronic kidney disease should quit smoking and tobacco. Simple dietary modifications like decreasing salt intake and in patients who are obese, limiting the caloric intake can significantly slow the progression of chronic kidney disease. Adherence to medication. At times we have patients who simply would tend to forget the important medications like antihypertensives, antidiabetic drugs, which can lead on to progression to chronic kidney disease. And avoiding unsupervised medication use, particularly analgesics, nephrotoxic drugs, which we so often used, including proton pump inhibitors, just for minimal symptoms without consulting anyone. So all these things should be avoided. Where does the physician's role come in? A physician should optimally manage primary kidney disease. So a patient who has certain glomerular diseases like IgA nephropathy, who has other primary renal diseases, should be optimally managed. What is the standard of care? So for polycystic kidney disease, we have certain set of guidelines. For IgA nephropathy, we have different set of guidelines. So a physician should primarily try to control the renal diseases which are inherent to the patient. If the patient has secondary diseases like diabetes and hypertension, they should be effectively managed. I would be coming to these subsequently. Obesity is a very important risk factor both for inducing chronic kidney disease and secondly for increasing the progression of chronic kidney disease. So maintaining ideal body weight, decreasing obesity is one very important factor in managing these patients. Another very important onus which as the physicians we have is to identify and treat any reversible factors. So very often we just label the patient as chronic kidney disease, not realizing that he might have some acute deteriorating conditions, whether it's hypovolemia, drugs, infection, obstruction, or a urinary tract infection. So we should try to look for and treat these important acute reversible factors. And as I said, chronic kidney disease is a marker for more cardiovascular mortality and morbidity, and we should aggressively treat other cardiovascular risk factors, whether they are lipids, whether there is oxidative stress. We should try to address these issues which increase cardiovascular morbidity and mortality. And finally, prepare the patient for care of end-stage kidney disease, whether it is dialysis or transplant which the patient opts for. Again, in chronic kidney disease, simple interventions actually do a great deal. Dietary interventions have an important role. So we rely a lot on renal dietitians and renal nurses for counseling our patients to take appropriate diet. There is some role of protein restriction. It's important to realize that as Indians, being vegetarians, majority of us, we already are on a low protein diet. So it's important to assess the protein intake and prescribe a planned low protein diet, which ideally should be 0.6 gram per kg per day. At times, it might be shifting the patient from low biological value protein to a higher biological value protein diet. For a diabetic, since they have significant protein loss, we recommend a dose of 0.8 gram per kg per day. This is also to accommodate for daily energy requirement because these patients already are restricted as far as fats and carbohydrates are concerned. Whenever we put a patient on a low protein diet, it's important to have a periodic and systematic nutritional assessment for these patients. Some patients are hypercatabolic, they tend to lose weight, they tend to lose their energy, and in that cases we can increase their protein intake to even up to 0.8 grams per day. Another very important component is restricting the salt intake. The salt should be restricted to 1 teaspoon a day for all patients with chronic kidney disease, whether they are hypertensive or not. Unless they have a salt-losing nephritis, that would be predominantly tubular interstitial diseases, where they are on a salt-liberated diet. Now coming on to the final part of the talk, and that is managing chronic kidney disease in patients who have hypertension and diabetes. While managing hypertension, of late a lot of stress is being given to measure the blood pressure appropriately. And this is what we have now called as standardized office blood pressure measurement. This pictorial is from the recent KDIGO guidelines on managing hypertension in patients with chronic kidney disease. And as you can see, they have very systematically highlighted the importance of taking blood pressure appropriately in these patients and then targeting the blood pressure to a standardized office blood pressure measurement. So the preparation would include rest, no intake of any caffeine 30 minutes prior to the measurements. The patient should have a bladder empty. The patient should be seated comfortably with the feet rested. We all know that the blood pressure and the cuff should be at the heart's level, we should be using a validated and calibrated oscillometer machines, because that is what we have nowadays. We should measure in both arms initially and tend to and subsequently record in from the arm which shows the higher blood pressure. We ideally should take average of 2 blood pressure measurements, and in certain set of patients we might have to rely on domestic or self-reported blood pressure measurements or even ambulatory blood pressure measurements. So taking a standardized office blood pressure measurement is central to starting a therapy for patients with hypertension and chronic kidney disease. Again, dietary modifications and lifestyle management are central to managing hypertension in these patients. We have to restrict the sodium. It has proven cardiovascular benefits, but again we have to be cautious in patients who have sought losing nephropathies. And more importantly, it has become a trend nowadays to use salt supplements. So these are nothing but potassium replacement or potassium supplemented salt. So you have less of sodium but more of potassium in these patients. Patients with chronic kidney disease tend to retain potassium, and that can lead on to hyperkalemia. So we have various salt supplements available in the market, including the traditional sandha namak or the rock salt, which all are rich in potassium, and we should be avoiding them. It's better to restrict salt totally rather than moving on to salt supplements. Physical activity again is a very important component. All the patients should be encouraged to have at least 150 minutes of moderate intensity per week. Again, it has benefits not only in blood pressure control but also in managing weight and quality of life. What are the blood pressure targets in chronic kidney disease? So that's where the role of standardized office blood pressure measurement comes in. The KDIGO recommends that all patients should have a standardized office blood pressure measurement of less than 120 millimeters of mercury systolic. You should realize that we are no longer talking about diastolic blood pressures, because if you control systolic blood pressures to this value, diastolic blood pressures would automatically come into place. However, we should know the limitations. There are certain set of patients who don't require this level of strict blood pressure control, especially in patients with advanced stages of chronic kidney disease, in diabetics, in patients who have a cardiovascular disease and in which the diastolic blood pressure goes below 50, in patients who are old, who are frail, and in patients who have a difficult to treat hypertension, because that would entail giving a lot of pills to control blood pressure, leading on to poor compliance. Therefore, individualization in each patient is key. The choice of blood pressure medicines: if a patient has proteinuria, then even till CKD stages of 4, we prefer to use either ACE inhibitors and ARBs, as these drugs have been shown not only to prevent progression of chronic kidney disease, but they also improve the cardiovascular outcomes. Now coming on to management of diabetes in patients with chronic kidney disease. Again, as the blood pressure targets, the HbA1c targets again should be individualized in patients with chronic kidney disease, depending upon their other complications, comorbidities, and their life expectancy. So if the patient is a young patient with no other comorbidities, no other complications, then we should target an HbA1c of 6.5. But for an elderly, frail diabetic patient who has other comorbidities and has hypoglycemic unawareness, we would be happy with an HbA1c of around 7.5 to 8. What drugs to use for diabetes? There are certain anti-diabetic agents which, besides controlling sugars, besides reducing HbA1c, also are useful in improving the renal and cardiovascular endpoints. Most important such new drugs are the SGLT2 inhibitors. We all have heard about Flozins. So SGLT2 inhibitors are the flavor of the season. They are just mild anti-diabetic drugs, especially in progressive stages of chronic kidney disease. They have been useful till a CKD stage 3 or till a GFR of around 20 at best, but they have significant cardiovascular and renal benefits with minimal side effects, which, if the patients are counseled properly, they can easily manage these side effects. The other such agents which are useful are the GLP-1 receptor agonists. They don't not only promote significant weight loss, but again they have significant benefit on the cardiovascular and renal endpoints. They can be used till a GFR of 15, and gliptins or DPP4 inhibitors, again, though having mild anti-diabetic effect, but still have significant benefit on the cardiovascular outcomes and some benefit on the renal outcomes. So these agents are the ones which we can use in patients with chronic kidney disease and which are likely to have both cardiovascular and renal benefits. So just the summary of the KDIGO guidelines of how to manage a patient of diabetes with chronic kidney disease. So as I said, in patients who have hypertension and proteinuria, ACE inhibitors or ARBs in all such patients, dietary modifications which I have already highlighted, individualized HbA1c targets ranging from 6.5 to 8, lifestyle interventions of restricting protein intake to 0.8, tobacco cessation, physical activity, and decreasing salt intake to less than 5 grams. Use of metformins and SGLT2 inhibitors if the GFR is more than 30. Use of GLP-1 receptor agonist if the GFR is less than 15. So these are the current guidelines how to manage such patients to attain renal as well as cardiovascular endpoint benefits. So just to conclude my talk, we now have increasing burden of chronic kidney disease and the resultant comorbidities, which come at a huge social and economic cost. Increasing awareness among public and the general practitioners is the most effective way in preventing renal diseases and their related complications. Screening and early detection in high-risk group offers most effective way of secondary prevention. Adoption of healthy lifestyle is central to prevention and slowing of progression in chronic kidney disease. And these are simple measures like limiting salt intake, cessation of tobacco use, regular physical activity, and weight loss. All patients with chronic kidney disease should have an individualized targets for blood pressure and glycemic control. With use of recommended agents for hypertension and proteinuria, we have ACE inhibitors and ARBs. And for diabetes, we have SGLT2 inhibitors and GLP-1 receptor agonist. In the end, my dear colleagues, prevention is always better than cure, and therefore we should do all measures possible to prevent renal health. Thank you.
Thank you so much, sir, for highlighting and optimizing kidney function. Sir has given an overview on comprehensive care for the prevention of disease in the matter of diabetes and hypertension by modifying the lifestyle modification so that we can control our diabetes, hypertension. That's how we can reduce the incidence of CKD in further life period. So thank you so much, sir, for your enriching session. Now I would like to invite Dr. Shashi Mawar to give a token of love to Dr. Mahajan. Any questions audience would like to ask? So we can open a floor for discussion. Anything you would like to highlight? If there are no questions, okay. Thank you so much, sir.
I have an important announcement. Anybody has lost a earring? Please check your ears. All females. I found one. That is the reason. Those who have left the hall and who were there in the morning, if you come across anybody who has lost a earring, please contact me.
Next, I would like to invite Dr. Arun Kumar. Dr. Arun Kumar from the Professor from the Department of Nephrology. So, sir will highlight on empowering the patients through their healthcare providers. So, I invite you, sir, for the session.
निकल दूँ I'm sorry for the delay. Very good afternoon, very good morning to one and all present here. I would like to thank the organizers for having me here, for one, and also for selecting such a nice topic about empowering patients through healthcare providers. Because whatever methods we have till now to prevent chronic kidney disease, which has been outlined by Professor Mahajan sir right now, they have limitations, and even after that, we are not able to completely stop the progression of kidney disease till now or improve the quality of life. The quality of life is still dismal for most of our CKD patients. And one maneuver which has been shown to be important is empowering patients themselves to understand about the disease and get involved in their management. Probably this is one thing which is really important in the coming times, and that is why in 2021 the International Society of Nephrology has chosen this as the theme for living with kidney disease, so that patients will understand their problems and they are able to deal with it in a better manner. Overall, all patients with chronic kidney disease, they are living with a number of hardships, and the only way these hardships, both for the patients and the healthcare, their care partners, namely their family members and friends, are going to change is by empowering them. So we'll just go on to our topic. First, why should we bother about kidney disease per se? We all know it is common, but how common is it? Nearly 850 million patients have kidney disease worldwide, and apart from the number of patients who are affected, it has a huge healthcare expenditure. $188 million dollars is what is the healthcare expenditure because of chronic kidney disease worldwide, and it is interesting to note that this accounts for nearly 3% of the GDP of the developed countries. So it has a significant burden on the healthcare expenditure of the entire country. And considering on an individual level, patients with chronic kidney disease, they tend to lose their daily work hours. It accounts for nearly 35.8 million disability associated life years overall, and this affects the personal level and the family level apart from the country level per se. Overall, CKD is the third most common, fastest growing cause of mortality worldwide, and by 2040 it is expected to be the fifth most common cause of morbidity and mortality worldwide. Overall, it is quite common. 8 to 10% of the entire world or patients tend to have some degree of chronic kidney disease. So, chronic kidney disease is common. We all know about it, is what we think. However, it will be surprising to note that the Global Disease Burden Survey, it had found that patients with even advanced stages of chronic kidney disease, namely stage 4 and stage 5, they had only 53% knew that they are having chronic kidney disease. So, even at an advanced stage where they are going to be symptomatic, 46% did not know that they are having kidney disease. And if you're going to see the earlier stages, be it stage 3 or stage 1 and 2, only 5 to 10% are aware of their kidney disease.
So when you're not aware of something, you'll not be able to treat it or you'll not be able to prevent it. So this is the reason why we should try to increase awareness among patients and their care partners about chronic kidney disease. The second problem is the number of nephrologists who are available in per se. So this was a study in 2018 and it was seen that there were only 1,639 registered nephrologists. So in the last couple of years or 4 years, we would have had another 300 or 400 coming out. So it would be around 2,000 right now. Considering what is our population size and the number of people who have gone out, migrated outside, this is a significant mismatch, a demand-supply mismatch which is there in the number of nephrologists also. Overall, a chronic patient, any patient with chronic kidney disease, nearly 1/3 of them are going to have multiple comorbidities. Apart from the one chronic disease what they are bound to have other comorbidities also. And most of the chronic diseases, the patients are usually treated as an outpatient. So being an outpatient, obviously they will have to take care of their self-care at home. Being at home, they are away from the professional care. So they will have to manage themselves or their care providers have to manage themselves. And in addition to the disease, they also have to have a normal life, because being a chronic disease, it is going to be there lifelong or for a significant period of life. So considering all these factors, we are having a largely undiagnosed and untreated population of chronic kidney disease. We are having an inadequate workforce of, per se, restricted nephrologists also, or even to other personnel. That we don't have any community programs or targeting chronic kidney disease wherein participation from either the physicians, healthcare providers or patients is included. And right now the focus on most of the healthcare innovations is on curative care. And we should understand that CKD per se does not have any cure. So we are having a disproportionate focus on curative care. So considering all these drawbacks, the only way where we can manage patients would be probably a patient empowerment to improve the patient involvement in the management of their own diseases. So we all understand what is empowerment, but the way we understand, the way each of us understands what is empowerment is different. So that is why we probably need a definition for us to know what is empowerment. So empowerment is a multidimensional process which helps people gain control over their own lives and increases their capacity to act on issues which they feel as important. So it is not the issues which we feel as important, it is not the issues which the care partners feel as important, it is what the patient feels as important for them. So they should have the control to take care of themselves. So this is what would be patient empowerment. And collective empowerment is when a group of individuals, be it the patient and the care providers or a community in per se, gets involved in empowerment so that they can manage themselves as a community as a whole. So this is what is collective empowerment. The first thing about important in empowerment is that they should know about the disease. There should be a literacy. Healthcare literacy is what is have to be imparted to the patients, and this can be provided only by either by the nephrologist or by the nursing personnel. So that is why we need to be aware of the healthcare problem so that we can teach it to them properly. And we should understand that what we need right now is shared decision making. What we always question is about whether the patient is adherent to therapy or not. But we need to move from this concept to something called concordance. That is, the patient and the clinician, they will have to interact each other and they should be partners in the therapeutic process, rather than the healthcare providers, be it us or the nursing personnel, dictating to the patients what is to be done. So for this, we need to identify what skill the patient has. We should understand what is their competence level and then provide the knowledge according to their competence level so that they can act according to it. So being a new thing, we need to, not one size does not fit all. So we need to understand what is going to be important for each group of patients. So we know for chronic disease as a whole, empowerment works. So what is important for CKD patients? So this was the CAN-SOLVE study, which was published by Donald et al. In 2019. This had included qualitative analysis from 6 focus groups, wherein around through phone-based interviews, CKD patients were included in the analysis. We had around 70% of CKD patients who were diagnosed in the last 10 years. Relatively younger population, considering it was abroad, it was less than 75 years, which they consider to be a relatively younger population. And they understood that the most important theme which the patients were concerned about was empowerment, activation, and the need for support. One, they wanted information about the disease, and once they had the right information, they wanted the independence to take the right action, and they wanted some support through the health journey. So these were the themes which was important for the patient. We need to understand this so that we understand what we can give to the patient overall. And following this, it was decided that a program would be started so that information is given for all CKD patients. Entire information sharing is done through all the patient groups, and a tangible support group is started, so which is tailored to both the patient and the caregiver needs. So this was what the CanSolve study had told. Considering it was just a couple of years back, they are told that the knowledge about the disease should focus on not only about the symptoms of the disease, but about how can they carry out their work life, whether they can continue their education, how to manage their financial independence, the importance of medications, the efficacy or adverse effects of alternative medications, whether they can travel, diet, and also about the physical health. So knowledge about all the aspects should be provided to the patient, in addition to practical supports, tangible supports, and also information sharing through groups, the patient participation groups. So, patient empowerment will require us to tell them about 5 E's. One would be education. We'll have to educate them about the disease, whatever we had seen right now. Knowledge about so many parameters has to be provided. 2 would be expertise. You should make them feel that they are an expert in understanding their own disease. So, for that, we'll have to train them properly. 3 would be equality. They should feel that they are equal to the healthcare personnel in managing the disease, and they have an equal role in deciding their treatment decisions. 4 would be experience. So by being in a patient participation group for a longer time, they tend to develop experience about how to manage themselves and patients who have similar disease. So that experience has to be given. And 5, engagement. They have to be engaged in all aspects of their care. These will be the 5 things based upon which patient empowerment has to happen. Not only in chronic kidney disease, and probably in any chronic disease. The effective self-management is something which is difficult for patients. It includes a complex processes and tasks, which includes both medical management about when they should visit the clinic, what drugs they should take, when they should get their tests done and all. It also includes behavioral management and emotional management, because considering it is a chronic disease, they're going to have lots of fear and frustration, and this has to be explained to the patient so that they don't get depressed because of this. And they should have a partnership with healthcare providers so that they will be able to solve their problems and also able to take actions which is needed for them. Once the patients have adequate knowledge, you need patient activation. They need to get activated so that they tend to work for their own self-care. And this, for this, we need to consider some resources. What amount of time is there? What amount of space we have? The finances we have to train these patients, they have to be considered. We'll have to understand that the information what we are giving is complex. So we'll have to make it simpler. We should see the readiness of the patient to learn or the care provider to learn before we go in. And we should teach them about what are the goals and about shared decision making. The most important challenges would be that there is limited or absolute no understanding about chronic kidney disease, about health management, and also the availability of health information is usually not under proper control. So the information may not be right in web-based sources. So all this has to be taken into account before we start activating the patients about self-care management. Once the patient tends to get activated or learns about the disease, their level of involvement is going to be different. Either they can be only passive and they can just listen to you, or they may not have the knowledge initially. Then once they have the knowledge, they may not have the confidence, and only at a high level of activation they will be able to support their behavior so that they can improve their own health. So there are multiple levels of patient activation which we have to assess what level of activation is a patient or the care provider is in. So what we have seen is that empowerment is important. It is self-management, has multiple processes and tasks. We need to activate the patient so that they are able to manage themselves better. So about all this, how are we going to assess it? How are we going to assess whether the patient is empowered or not? Obviously, we need validated tools for it. The couple of tools which have been validated in CKD patients is the CKD self-management knowledge tool. So this is about the CKD specific knowledge about self-management. It is a validated 11-item questionnaire, and patients just have to answer true, false, or I do not know. And this is with regard to their own self-management in the prior 6 months. And This is scaled in a Likert scale. 1 to 5 is a scale which is used. The next one is a patient assessment of care, and in this, the extent of care which they have received according to the chronic care model of any chronic disease is assessed. It is a validated 20-item tool where 5 subclasses are usually assessed about patient activation, the delivery system, about the goals which the patient sets, problem solving, and whether follow-up or coordinated efforts are there present or not. This again has to be assessed with the history in the last 6 months. This again is a Likert scale. Likert scale are usually used for patients because it is easier for them to understand, and it has excellent reproducibility also. The more commonly used one right now is a patient activation measure. Earlier it was a 22-item one. Right now the 13-item patient activation measure is used. It measures the knowledge, skills and confidence for self-management. And based upon the scoring, it is scored from 0 to 100. Based upon the degree of score, we can say if the patient is completely disengaged from his care, if it is less than 47, or he is good enough to sustain himself, self-sustain himself. So this is a scoring which is done. The scores are there. Do they work? Do they work very much properly? They are validated scores accepted. So the PAM score was right now, in a couple of months back in 2021, it was assessed in 942 CKD patients, and it was seen that it is very effective. It is promising for those with chronic kidney disease, and it is a reliable instrument for assessing the patient activation. So this is something which is shown to work, and we should try to use it, and it has excellent reproducibility also. So we know that patient activation is important. Whether is it important for clinical outcomes? So anything which does not have an impact on clinical outcomes is not important for us. So this study, it was published in 2018. It was a SPEAK study. It was among young patients. Usually it is the young patients who don't have proper complaints. This is because one, they don't understand the importance, and two, they have multiple things on which they concentrate, because of which their knowledge about their own disease and managing their own disease has a problem. So in this study, around 625 young patients around 16 to 30 years were included, of which 71% were on dialysis and 30% were transplanted patient. This was an online survey which was conducted by the UK Renal Registry, and they had found that patients' well-being depended upon whether they are independent or not. This independence depended upon patient empowerment, one. Two, medication adherence, it depended upon patient activation. So any patient who was already activated, they tend to have a better adherence to medication. So this shows that patient activation and self-empowerment does affect medication adherence and well-being in both transplanted patients as well as dialysis patients. So as I mentioned earlier, in 2021, the World Kidney Day theme was about living well with kidney disease, and in this, a number of steps were told in order to improve the patient outcomes. We'll have to address the symptoms and the life impact of the patient, which we are already trying to do. We need to educate, engage and empower the patient. This was told to be an integral component of living with kidney disease. In this, the patient's ability to work, patient's ability to travel, to study, the impact what the disease and the management has on friends and family, the financial impact, the lifestyle changes, all of this has to be educated to the patient. And this a number of programs were conducted from last year for it, and we have a number of trials which are coming up in order to make sure that patient empowerment is spread to everyone. So what is that we expect from an empowered patient? We want him to track his own health, him or her to track his own health. They need to decide what information he wants to share and to whom. We can't expect him to share all the information with all the clinicians. He has to have the rights to decide what information he can share with whom. He can use the online information to verify his diagnosis and therapies. We should not have issues with it or have an issue that he's questioning us about it. And obviously, he has a right to want instant feedback and advice from the healthcare provider. So this is what we are expecting from a patient who is empowered. The barriers for us for this would be the fragmented healthcare system, not only in India, worldwide probably. The concerns of privacy when telecommunication is being used. The software systems are still outdated for its overall use. The one thing what we are looking forward would be about home hemodialysis. So this is something which has come up in a big way in the New Zealand, Australia and the Canadian countries. And in this we should understand that the patient empowerment, patient role is even more important. We need to educate the patient early and repeatedly so that a proper home based dialysis system can come up in our country. And studies have shown that the most important challenge for this system would be the self-efficacy or the self-efficiency of the patient involved. The second thing what we need to take care would be about the web-based tools which are there for patient empowerment. We consider online methods of learning to be adequate in the present COVID era, and there are a number of resources which are available online. So are they good? Are they effective? So this was one of the articles which was published in a Canadian journal in 2019, where they wanted to know about the content and the quality of websites which a CKD patient can use. And on searching, they found that there were around 2093 websites which gave some data, but around 115 were the ones which are useful for patients as a whole. And most of the websites tend to deal on understanding CKD, the symptoms and the diet. Travel, finances, emotional support were not dealt very well in these websites or online web-based tools. Almost all the web-based tools, they had poor readability. This was assessed by using a grade level and a reading ease assessment. They had a poor readability. And CKD self-management, about what we are concerned about in empowerment, was seen in less than 1/3 of the web-based tools. So there is a big gap which needs to be addressed in these web-based tools. And this was another study which was published last year to understand what is the patient's perspective and the nephrologist's perspective about the smartphone apps which are available. So on evaluation, they found that there are around 28 applications apps which are available, 11 in iOS based system, 12 in an Android based system and 5 in dual platform. And what they could find is that the acceptability, the app acceptability to patient and the nephrologist together was not there usually. One, the consumer ratings which are given in the apps varied with the patient delay satisfaction and acceptance. So probably the smartphone apps are not adequate still for the knowledge about CKD and for empowering patients. So what we have to do. So as this year's theme is there, we need to bridge the knowledge gap to ensure that better care is provided and patients are empowered. We need to promote community participation, facilitate the migration to newer technologies and web-based tools, develop better software solutions, develop the skills and expertise for this, and improve the self-care for these patients. So to conclude, we should understand that patients are an essential part of the solution to improve the patient care. We need to accept that they have the experience, the patients have the experience because it is their body, they have the will and the ability to contribute meaningfully, and we need to make them a component of the health related decision process always. Patient empowerment is going to play a pivotal role in the days to come for all chronic diseases, more so for CKD where there is no curative care. And for achieving a high quality sustainable health care, we need to make sure that patients are empowered. Thank you.
Any questions from the audience?
Likert scale, it is usually ranges from 1 to 5 or 1 to 10, where you're going to ask if the patient is acceptable for it or not. Like consider that we consider 1 as acceptable, less acceptable, 1 will be acceptable, 2 will be more acceptable, highly acceptable. So we are just asking them to grade their acceptance of something. It is a visual based scale, which is quite easy for the patients to tell how much they are accepting some manual. It is something which is commonly used. I don't know if I'm...
Any other queries? Check the chat box also. Okay, then we'll move forward. Thank you, sir.
Thank you.
Before we proceed further for the next session, I would like to invite Dr. Sanjay Gupta, Professor, Department of Nephrology. I welcome you, sir, for accepting our invitation. Sir, we know that he is renowned for his excellence in the field of nephrology, and he is a academician, and his excellence has many levels to his credit. So we are highly honored to have you, sir, here. Now we'll continue with our session. I would like to invite Dr. Shashi Mawar, Associate Professor, College of Nursing, for continuing the session on empowering, that is empowerment of the patient from nursing perspective.
So, a very good afternoon, everyone. We have already listened to Dr. Arun regarding the perspective of a nephrologist regarding the empowering patients towards healthcare providers. So, I'm going to talk in brief about what is the perspective of a nurse regarding empowering of patients. Like he has already said it that empowering the patients, it not only helps the patient to take care of themselves, but it also helps the nephrologist so that half at least 20% of his work is done, and then continuous monitoring as well as continuous management on various aspects of their lifestyle as well as to take care of their own health. They have to come for less follow-ups, and they are entertained well by the nephrologist when they are maintaining well. So empowerment has its own significance in various fields of knowledge built over decades, and it is influenced by various factors like the self-help movements, that is by their own selves or with their family caregivers or by the community, and the health education which we provide at all levels, as well as the physical environment in which they are living as well as while they are being treated. So the empowerment concept is sometimes translated as apodermento or apodermento in Portuguese, being defined as a health promotion strategy, and the healthcare providers as support. So basically the healthcare providers, they are acting as a support so that the patient takes care of themselves in their self-management, allowing the practice care strategies for prevention of CKD. So there are various factors which are related to the health and well-being. You can see this in this chart that only 10% of the factors are related to healthcare, but still we have to pay a lot of attention to these this 10% even. So these are some of the interrelated social determinants of health, which include healthcare system, the food, the environment in which they are living, the community and the social context, the education level which they are having. And based on all this only, we will be able to teach them the strategies, how they can take care of themselves along with the family caregivers. So our main focus will be on the risk factors, specifically those people who are highly at risk for getting CKD. So the main factors, they are diabetes, age of 60 years or older, kidney disease present at birth, that is maybe any congenital problem, autoimmune disorders, bladder outlet obstruction, or it can be based upon some races and even genetics. So why there's a need for empowerment? Because kidney diseases, they usually progress silently, often destroying most of the kidney functions before causing any symptoms. So the early detection of the failing kidney function is crucial because it allows suitable treatment before the kidney damage or deterioration manifests itself through other complications. So to take care of the kidney issue, we need to see that we are taking care of the preventive strategies right from the primary prevention till the tertiary prevention. So primary prevention is of utmost important, so that we are not we are helping those people who are the general public who are at risk for developing kidney disease. So in the primary prevention aspects, we need to educate them about how to identify those people, how to manage their obesity, how to improve their glycemic levels, how to control their blood pressure, their dietary management, and their healthy lifestyle also. The secondary prevention, like fine, we already know that CKD progresses silently and the symptoms do not appear very fast soon. So but even if CKD the person has got the disease, even the early detection is going to help us out a lot, so that we are able to treat the patient in time and prevent from further progression of the disease. So what do the patients mostly want from their healthcare experience? A study has shown that 75% of the patients want a more personalized relationship with their providers. So they want to have a one-to-one contact and individualized care, a tailor-made care for their own needs that should be taken care of. And 60% of the patients want more affordable and transparent pricing. Everybody knows that healthcare costs have been inflating or has been increasing over a period of years, and as the disease progresses the cost also increases. So since they want at an affordable and a transparent pricing, it is very important that we prevent the patients from having kidney diseases. Then they also expect convenience and digital tools as their priority, so that they get the information at their own doorsteps or at their own wherever they are working or living, at their own place itself, so that they are able to have an access to it and manage. And these things, they help empower patients so that they can be active participants in their own care. So this helps them to in their own decision makings. So there are some strategies to empower CKD patients. First one is provide convenience. All the patients, they require a convenient time for their appointments. They expect scheduling of the appointments on the day when they are able to have access to the healthcare facility. It helps if we reduce the waiting time. Then strive for practices to break down the barriers of indifference, leading to patient acquisition as well as long-term patient retention. The second important thing is, second important strategy is give clear information and actionable plans. It is expected by the patients that they are being provided with clear and achievable action plans, and those action plans, they should be broken down into simple as well as measurable steps. Health professionals should share their knowledge with the patients through patient portal, website blogs, newsletters, or any other avenues, whichever is feasible in their own settings. It is also expected that they are provided with the right information to the patient to develop and confidence that they will be able to overcome any complex health issue even. The fourth strategy is to encourage use of shared patient portals. That is, they should be having an access to the electronic health records so that they become more active and they are able to take shared decision making. Enable to share their data with other healthcare providers to reduce unnecessary investigations. Otherwise, what happens is, most of the time the person goes to one after the other physician and they keep on just getting investigated. So with this accumulated knowledge, confidence and self-determination, patients may take more responsibility for their own health and be more involved in their treatment. Patient activation and empowerment. Patient activation basically refers to the patient's knowledge, skills and confidence to manage their health and healthcare. And patient empowerment is involving the patient's self-efficacy and capacity to make informed decisions about their health. So it is not only the activation, but we should be helping the patient in their empowerment. So there's a move towards empowering patients to prevent kidney diseases. The most important thing is CKD screening, and screening should be targeted to the high-risk individuals and needs to be implemented worldwide. The KDOQI guidelines, they recommend screening of high-risk populations, which include individuals with hypertension, diabetes mellitus, and those older than 65 years. And this includes urine analysis, a urine albumin creatinine ratio, measurement of serum creatinine, and estimation of GFR, preferably by the CKD epidemiology collaboration equation. And it is the most effective approach, cost-effective approach. So we need to bring about some kind of behavior change among these patients. And these behavior change includes early identification of health problems, lifestyle modifications, that is regarding their diet, their physical activity. When we manage their diet as well as ask them for physical activity, we are managing hypertension as well as controlling hypertension as well as controlling their obesity issues. Then self-care management in the regular monitoring of their blood glucose levels, blood pressure levels. Then self-monitoring on regular basis, and stress management, as all these are the factors related to the development of kidney diseases as well as other comorbidities which can later on lead to CKD. That compliance is very, very important for these patients. We need to educate them regarding the compliance. So compliance to treatment as well as compliance to follow-up, compliance to healthy lifestyle, and not to use over-the-counter medications. Self-management includes controlling blood pressure as well as controlling blood sugar levels. What you should not forget while you are taking care of any patient in any healthcare setting, not only in the department of nephrology or not only taking care of chronic disease CKD patients, early CKD has no signs or symptoms, so we need to see that we are able to screen as well as at least the high risk patients and prevent CKD among them. Chronic kidney diseases usually does not go away, so they need a lifelong treatment, and so we need to prevent progression. Kidney diseases can be treated. The earlier you know you have it, the better are the chances of receiving effective treatment. So if you empower your patients regarding these issues, they will be able to self-manage themselves. Blood and urine tests are to be used for kidney diseases, and kidney disease can progress to kidney failure. The outcomes of all these empowerment strategies will be, when the patients they are engaged and active in their care, they are more likely to have positive health outcomes, and it has been observed that the quality of life of these patients, it is usually deteriorating as the disease progresses. So if they are if they are empowered, even their quality of life will be affected and it will be better. Engaged patients feel empowered and motivated to take action, so they will stick to the treatment plan, take their medications and follow the provider's recommendations. With the help of a digital engagement tool, there are several tools which have been tested in several places. There is a patient bond platform, and there are various applications also available, which many studies have presented as evidences, and they are found to be satisfactory. And recently we have used an Utsarjan app for nephrotic syndrome patients in our own. We have done a study on Utsarjan app for nephrotic syndrome children in our setting itself, and it was the caregivers. It was for the caregivers how to take care of nephrotic syndrome children, and the satisfaction level was more than 80% regarding that app. So, and it motivates the patients as well as the caregivers to incorporate the healthy behaviors which were there available in the app. They were videos on how to do a regular monitoring of urine dipstick or for protein presence, etc. So there are some challenges to empower the patients. Patients may not want to take the responsibility of their own health and choose to rely on healthcare system to treat the problems which otherwise could have been prevented or avoided. So we have to see that we make the patients self-reliant so that they take their own responsibility. Healthcare providers think of disease and treatment only. So the mindset will have to morph to a more preventive approach where we are thinking about the problems that may arise well before they actually do. So healthcare providers, they are traditionally taught to make the clinical decisions based on one or two active issues that are directly in front of them. But the patient's need is their care should be tailor-made, and they should be provided a special attention, and individualized approach should be there for them. So the take-home message is, care is not one size that fits all. Some patients need to talk through their concerns and worries. Dr. Arun has mentioned that some patients need to talk about and ventilate about their psychological issues, their social issues also. So we need to see that even those issues are being taken care of. A simple do this and the doctor may work for some but will fail miserably for others, resulting in non-compliance or dismissal of advice. And the most important one is, the basic facts are easily found on the internet. However, so much information is unfortunately misleading, conflicting, frightening, or out of context. So the healthcare professionals need to lead the patient through the noise into what is sound advice and the patient appropriate. So it is not simply defining what to do, but also why and when. With this, I conclude by saying that we all should be, when we go back to our own settings, we should be able to prevent kidney diseases. Thank you. Any questions from the group?
Any questions from the chat? Okay, so thank you so much, ma'am, and wonderful thanks to Dr. Arun also. Both have taken a session on empowering the patient from the healthcare provider perspective of a nephrologist, as well as we have also seen a perspective of a nurse. and they have highlighted on the movement from the adherence now to the concordance. They've also said that empowerment means activation and support, and patient, it's not only the information, but also they need to engage themselves in the care part of it. So that's what being highlighted in both the sessions. And also they have focused on, Madam has clearly focused on compliance. It's not only about the adherence to the treatment and the follow-up, but yes, compliance about the lifestyle modification, which we have to continue so that we can prevent our diseases. So thank you. Now I would like to invite our next speaker. Sorry, sorry. Okay, now I would like to invite Professor Sanjay Gupta. So please come forward and give a token of love to our speakers of the sessions, Dr. Arun as well as Dr. Shashi. It was a wonderful session.
कैमरा क्या है? कैमरा ओके प्लीज कम. Yes. Yes. हाँ इट विल बी ओके. नहीं अच्छा नेक्स्ट करते हैं.
नहीं इनका सर इनका नहीं. Moving to the next section, I would like to invite Mr. Hamid Ali Said Al-Shari. He's from Oman. He's a renal nurse. So I welcome you, sir, for highlighting us on the topic of prevention of CKD progression and as from the nursing perspective. So over to you, sir. Sir, please unmute yourself. You're still not audible. Sir, please unmute. Yeah. Yeah, over to you, sir.
Good morning, everybody. My name is Hamid. First of all, I would like to introduce myself. My name is Hamid from Sultanate of Oman. I'm working in Sultan Qaboos Hospital, which is located in the south of Oman. First, before we start, I would like to say thanks for the organizers for the invitation.
Excuse me, sir. Please make it full screen.
Yeah, sure. You want the full screen?
Yeah.
The slideshow. Tell him slideshow.
Sir, put it on the slideshow.
Okay.
ऐसे चल रही है.
Before starting, can you please say thanks to the organizers for their invitations. And my topic will be about the prevention of CKD, sedation, nursing intervention. Because of the time limitations, I will cover almost 20 minutes because I was prepared to make some information and about the definition and the stages and stages and the process of CKD, what point about active, middle and only in fast and this coming it. As you know, my topic will be CKD and nursing intervention. We will start first with actually because of the time, I will go five slides.
He can take his time.
Parts of these slides regarding the definition and so on. So everyone knows that CKD is our patients. So we will go because this is already mentioned. Some of the patients, we know the function of the balance, neutralize, control the blood pressure, and so function also like activities. And this is already some patients by this. I'm not sure about the hair name. So the definition of the structural or functional abnormalities of the kidney for continuously.
Excuse me, sir, your slides are not moving.
Sorry?
Sir, your slides are not moving.
The voice not clear?
Voice is okay, sir. Slides.
The slides?
Yeah, it's okay now.
It's okay now? It's okay now?
Yeah, sir.
It's like this because I told that I cannot see myself. So I would like to see, I want to see the audience.
It's okay, sir.
Is it clear?
Yeah.
Functional abnormalities of the kidney damage can be with or without decrease in GFR because of the pathological abnormalities, or sometimes we have GFR also indicates GFR less than 6 because only patients who are until CSB 4 and 5. This is a big I want to focus more in my topic, which is the strategies of slowing down the dose. So let me go with the slide number. Slide. Yes. From this slide, we can start about the how we can slow down the progress of CKD. Every healthcare provider, we know that the early treatment can make difference. So if we are detecting early detection of that one CKD, we can prevent the complication and also we can improve the quality of the patient's life. So how we can do it? We can do by when we need it. When we need to go for the conditions because of four things, four points, like living and death, like heart attack, just heart failure, and stroke. This is very important for us, and also for us and for the patients. We have to consider this, and also within the condition to the to kidney failure or insulin. Because some patients they can if we are slow, we don't have this. It will take like more than 10 years or 5 years into the our intervention. And also within the communications and repair the patients. Repair the patients for the classes for national patients. Some patients do not know if we didn't take the TTP, it's difficult for them because their life will change. But if we give them a chance and repair small changes, habits, and behaviors, especially if we take the population of the one from the Asia, we will get them to prepare their lives in a time. So what we have to do is we will focus on five points, which are mentioned above, like the lifestyle conditions, minimum drugs, dehydration, medication adherence, and exercise. I will go through this fast because of the time. Sorry for that. So we start with the first one, which is the lifestyle medication. The lifestyle medication, we have to focus on the vitamins, exercise, diet, moving, moderate alcohol intake, and stress management. Okay, as you know, is habits such as like when you change in changing the behaviors that is difficult to adapt with it, and also making changes in behaviors is very complex. I think that is difficult. So, by frequent reinforcement required. So what we need to know is the first one, like exercise. We know that conditions generally they are many of them physical they are weakness, tiredness, and fatigue. So what we have to do is we need some physical activities to improve their body and we can do something like you can have different different exercise. Depending on the intensity of tolerance, specific exercise can be or should be performed on the patient. Some people can do in aerobic exercise, and others they can do muscle exercise. And some of them, according to that, according to the tolerance, we can give the patients. We can give it to the patient. So, this is the first one, the exercise. The time, according to the lectures we taught before, really we are very happy about the diet, this potassium, and also to mention about the sodium and it's important to the elimination of sodium for the stimulation. I'm not talking about the patient analysis, analysis for that one. I'm talking patient on the what we need to do is salt restrictions. We have the salt restrictions. So, I think Dr. Singh, he highlighted about the importance of salt restrictions. So, we have four elements in the diet, like four elements mentioned, like sodium, potassium, phosphorus, and protein. In the sodium, the salt really consists of salt. So, the goal is to increase them to 2,000 milligrams of sodium each day. Only 2,000 milligrams. So, we have to include the patients, and we can also we can leaflets. One leaflets for we can make a leaflets for the patients and also for the patients who are in the clinic. This is very important. We can give them data about all the diets they can eat, and also these different kind of food which are high or low in that one in the sodium or the calcium or so the sodium is important. There is a list there. I don't know all this time all the time. So less sodium diet will help to lower blood pressure, and this is very important. Okay. The second one, densities for knowing so. So according to that, what we have to do is like we have to keep it in our mind or to consider that one takes almost 1 equal to 2,000 milligrams of sodium. So it's very close to that recommended diet. So we have to take this one spoon, one teaspoon. Also, when eating in with relatives or friends, we have to request this dish without salt. And also we have to eat and encourage them to eat a fresh food. And also check read the label on fresh meat and because many factories they are putting extracts of the meat in order to make the meat last longer. This is the experience that we need. So we have to consider and think about it. And all don't eat or don't consume matching or further pizza, rice or fried chicken. This is very hard for the patients. And don't forget to read about the nutrition pack. The nutrition pack is what is needed and food contains in the food. So the second one is potassium. Potassium is one of the elements which we have to think about it. Potassium, what we are doing is sometimes in some in kidney they not remove extra and it's difficult to manage it. So we can do this one using the amount or the tiny amount of potassium. The potassium are of 2,000 mg and no more than 3,000 by day of for that elimination. Okay, there is some things for that. We can focus on the third one, which is only the vegetables, because only allow some of the potassium to filter into the water. Store deep fruits and vegetables that are low in potassium. I will mention the list of food or fruits and vegetables which are high and low in potassium, and we have to consider that. Like fruits, we have banana, dates, kiwi, and so on and so on. And the vegetables, we have broccoli, we have corn, we have cucumber, and green beans. So, as I know before, as mentioned, we need a diet pocket is very important for the patients. We have doctors instructed exactly into 800 to 1,000 a day. Okay, it's important for the board for especially in the blood, sports is high. It's most patients in anemias and kidneys. So we have to take care of this very things for knowing the sport and eat my food and vegetables. Eat food with no sport, and there are some table showing here some foods which is high and low in the fourth one is also very important and can be found in the animal or plant foods, and we have to conform them, and we have to encourage them to eat a low protein. And also family engagement is very important. Family engagement in the diet, in the lifestyle is very important. We have to encourage them to be a part of this. Also, we have also some diseases that the third one we have, as I mentioned, lifestyle, exercise, diet modifications, and we have also smoking. It's very important. The second part, we have to stop smoking and concentrate on stop smoking. This can down methods of how we can stop the smoke. We can do actually like we have pharmacological method which is nicotine restricted, and we have behavioral the pharmacological we can give nicotine restricted. And behavioral it's like a how to like it's, we are trying to screen the fruits of for example, we give him like 1 month, and we give for the first will one day he will only in 1 week. The second week will start with the 2 days. Gradually he will reduce that. He will reduce that one. And although I think some students during this process they will get like a ticket, and so some information can be given in between. And also they are giving they are recommending tonight they take the next 15 hours drink enough water and avoid the smokers. People are we have they have to avoid them. And we have here alcoholic. Alcoholic people, we are talking about the people they are consuming alcohol. So we have to moderate it. What we are smoking, we are focusing on because it is problem because it's linked with the increase the blood pressure. It's increase the blood pressure, and it's by the increase the blood pressure it's really damage the kidney as well. So we do the 51 lifestyle medicine is medicine. This means any type of changes like significant changes in emotional or it will lead to the which lead to the high pressure and also change in the weight. So what you have to do is the person need to do something like focus like diet, for example, eat healthy diet and avoid caffeine is very needful for coordinated coffee, I mean, not coffee, coffee, sorry, coffee intake. And also the sleep. We have to give the patients and enough adequate sleep of 8 to 10 hours a day. And also and this is sleep by let them to sleep in one time and woke up in one time. And this is very important, and relaxation, like I think it is very important for the stress. And hope you reading this part and clear so far.
Yes.
So we go the second one, which is minimum use of drugs. Is very important. We are talking about the toxic drug, which toxic drug. The minimum use of protected by leads the pressure damage the kidney by increasing the blood flow to the kidney. Those drugs are increasing the blood flow to the kidney. So we have to take care of this use by life. Especially like non-steroid anti-inflammatory drugs like endorphin, ketodopamine, and naproxen, and also antibiotics and drugs used to treat cancer like chemotherapy and drugs that used in medical imaging testing like STD. We have to take care of this. This drug will increase the blood flow to the the kidney and it's lead to the damage of the kidney. The second, and there is a case for using do not take over the pound drug for relieving pain. For example, like and if you are taking painkiller like paracetamol, drink water 16 glasses daily. It's very, very important. And do not take antibiotics for fever or for the fever over the counter. Always you have to consult the health or healthcare professionals for that. Inform healthcare providers or healthcare workers about the kidney disease. If you have any test, it's very important. And also every time you have and also one person heroin or cocaine is very harmful. This type of drugs. The third one is dehydration. Dehydration is very, very important. Dehydration is because of one in water due to condition of diarrhea or urinary loss. So we have to keep the water in good enough for the business because it's not to open the business and it's very important for the business. So water can be removed in the water. So from the body in form of fluid and water also as keep the blood successful. In circulation, that cannot say vomiting is increase the water is content in the body and increase the urinary circulation. So what you have to do is you have to do manage that hydration. If hydration is well maintained, the technical condition is reversible. So what you have to do is we have to drink water at least 8 to 10 glasses per day. So we have to measure cooling off during the second is another point which I will talk about it later on. So during the daily we have to use much much the urine and see the darkness also. We need to the color of urine because normally the urine is light yellow or colorless. So if the turn it's turned to dark yellow, this is dehydration in the body and you have to control your control. The fourth one is medication adherence. I mean, medication adherence, we know the agents of CBD agents in the large number of girls, and they are the medications, which lead to uncontrolled hypertension and chronic kidney. So what we have first, we need to know the reason behind medication and adherence. If we know those, if we know the reasons, after that we can go through the which are the concept for medication adherence. So it's the reasons are attitude, distance. Some reasons they are not positive papers, but they are not taking medication. Forget and failure of medication scientific, they don't want medications is very hard for them. So they are ignoring and they are not adhering with the medications. And also we have obesity, the medication for this is common right now, and that is for the role and responsibility to indicate them about increase in the also, the cost of drugs in some countries, combinations, it's difficult to get drugs. And also, type of symptoms. Some reason, because most people, they will not take medication. They are simply, who don't have symptoms, nothing, I'm fine, I'm fine, so I will not take. So we have to consider this and go to the how to transform on medication care. So what we have to do is to take the prescribed medication as the golden rules. Keep it in their mind. Keep the medication as a golden rule. And you have also, they are likely to forget the medication. So keep family members as can share as they can for their medications, allowing them to take their medications. Packing can be done in advance morning in the medical with help of family members. In case of travel, pick up your medications like your clothes, like your money, and whatever. So it's important to encourage them and educate them about the importance of medication in order to prevent the further complication of CKD. The last one, which is showing your the last one is safety rules. As mentioned before, what is the meaning of safety rules? The safety rules are rules that is the safety division safety rules are means that exclude the basis from business such as fever, diarrhea, and anemia. In that case, the patients they are not fuels. They are not influenced by sleeping, by diarrhea, vomiting, and so on. So the drug the drug need to reduce the blood pressure or in the blood flow. So the patient already they don't have they know or she knows their fluids. And on the other side, if we are giving them drugs, we need to reduce the blood flow. So that's the kidney injury will happen for the patient. So we have to teach and we have to let them to know that they can take that medication if there is protein or diarrhea. For example, if so medication in CDs or other medication vomiting and diarrhea, if it's once, please ask. No need to take the medication. If it's once, if it's more than 2, 3, 4 times, you can take the medication and you can also to ask after 1 day to discontinue the medication because after 2, 3 days, people continuously taking medication. So, what is the text for that? We have to drink the water. Mostly going out during city by avoiding the bottle container having marks. We have to see the urine output and also the limit of urine. Normally urine light yellow or purple or if it's yellow, if it's because what we are talking about the dehydration, we are talking about the dehydration. This is the dehydration. This is very important point. If it seems that yellow, it seems that skin get damaged is dehydrated. What is this? We will go to communication. Yeah, I believe more than so. We do what I think is special or functional abnormality of the kidney for 3 months because of high blood pressure activities are the most common causes of kidney failures. None of prevention takes which are most are real depending of those condition. Early symptom infections and manipulation the abortion for the prevention of things including them. So, infections is very important. It cannot be the same. So, what information can be stored? So, will approach treatment, behavior strategy, and science. And thank you for your attention. Hope I can finish by cover all points. Okay.
Okay. Any questions from the audience? Others, those who are virtually attending the program, kindly mute yourself. Any questions from the audience, online, offline? Thank you so much, sir, for highlighting on prevention of CKD. Sir, Sir has highlighted on not only the prevention of CKD, he has also highlighted the interventions by which we can delay the progression of the CKD. So he has involved the use of how to do a minimal use of the drug, hydrating the patients well as maintaining or encouraging on medication adherence and following the sick day rule. So these are the some measures by which we can not only prevent but also reduce the progression of the disease. Thank you so much, sir, for your session. I would like to invite Professor Dr. Gupta to give a virtual token of love from our institute to you. Over to you, sir.
Amit, you have done a wonderful and it was a very enlightening presentation on the prevention of a chronic kidney disease. Dr. Hamid, you have done wonderful and it was a very enlightening presentation on it was a very enlightening presentation on the prevention of chronic kidney disease nursing interventions. You highlighted the dietary management, you highlighted the drugs compliance, adherence to the medications, and these are very important for the prevention of a chronic kidney disease. This was a nice presentation, and I think there is a memento for you. So we will send it to you.
Thank you, sir. Thank you, Mr. Hamid. Next, I would like to invite our next speaker, Professor Dr. Sanjay Gupta. Sir is going to highlight us on safeguarding kidney by managing hypertension. Sir, next.
How to this is it, right? Okay. Okay. Really comfortable. Really comfortable. Yes. Good afternoon, everyone. At the outset, I would like to thank the organizer for inviting me for this meeting, and it is my honor to present in World Kidney Day in All India Institute of Medical Sciences. Okay, my topic is basically a safeguarding kidneys by managing the hypertension. So we will be discussing about the hypertension mainly. First is the importance of hypertension kidney disease will be discussed, and basically hypertension can cause kidney disease, and hypertension also leading to progression of chronic kidney disease. Okay, both things are there. Then we will discuss about the pathology of hypertensive nephropathy. Then what are the targets, BP targets, which we need to be achieved, and how to manage hypertension in a patients with the chronic kidney disease. Hypertension and kidney functions are intimately related with each other. Hypertension is either the cause or the consequence of chronic kidney disease. Hypertension is a major cardiovascular risk factor. We are all aware that hypertension is a cardiovascular risk factor, but it is also a risk factor for the kidney disease. Hypertension is the second most commonest modifiable cause for chronic kidney disease progression after diabetes mellitus. There are two main objectives for the treatment of the hypertension in patients with CKD, and that include slowing the rate of renal function loss, and second is the decreasing the cardiovascular morbidity and mortality. So we come to essential hypertension. Essential hypertension is a classically defined as hypertension that occurs in absence of a non-secondary cause. Basically, it is the hypertension without any cause, which is known as essential hypertension. there is a hypertension epidemic in our society, and data shows this. In US, the prevalence of hypertension between the ages of 45 and 54 has increased from 11% in 1930 to now 31% in 2000. The incidence of ESRD attributable to hypertension has increased nearly eightfold over last 40 years. It is me.
Participants, kindly mute yourself. Uh, Participant, Ms. Rose, kindly mute yourself.
हमारे कंट्रोल में है। रोज को म्यूट करो।
Okay. So we start again. Then hypertension-related renal diseases. In United States, hypertensive nephropathy accounts for nearly 1/4 of incident dialysis patient. So out of 100 dialysis patients which start in dialysis, 25 are directly attributable to the presence of a hypertension of unknown cause. Hypertension nephropathy is the second most common cause of ESRD, the first one being the diabetes. The worldwide reported prevalence of hypertension nephropathy is high and varies from say 27% in France and 21% in Italy. So this is uniformly high. So approximately, and similar data is there for the India also, around 25 to 30% of the patients who are starting dialysis, the ESRD is due to the hypertension. So hypertension per se is a very significant factor in the renal disease. Also, the progressive chronic the hypertension is responsible for the progression of chronic kidney disease, regardless of the etiology of the chronic kidney disease, be it diabetes, be it is a vasculitis, glomerulonephritis, chronic glomerulonephritis, even a stone disease. Once the chronic kidney disease sets in and patient is hypertensive, the disease progresses relentlessly. And so regardless of etiology, a vicious cycle of progressive decline in GFR occurs once hypertension develops in patients with chronic kidney disease. So, the question is now, does hypertension cause renal disease? Does hypertension cause renal disease? So, there is actually no doubt that severe hypertension, what we call a malignant hypertension, causes a progressive renal failure. Lowering of BP in this condition can slow or prevent progression. So, malignant hypertension has been definitely been linked to the renal disease. But there is a controversy: does mild hypertension cause progressive renal disease? The mild hypertension is so much prevalent, and we don't tend to see so much of the renal disease in the patients with mild kidney disease, mild hypertension. So this question arises, but there has been various studies, and they have shown that even the patients with the mild hypertension are prone for the hypertensive nephropathy or kidney disease related to the hypertension. There is a direct relationship between the level of blood pressure and risk of developing CKD. In a particular one study, it has been shown that for every 10 millimeter increase in systolic blood pressure, the hazard ratio of developing CKD is 1.3. So that roughly translates that every 10 millimeter rise in mercury, 30% of the rise in incidence of the CKD is there. Also, because of these patients of a subset of patients with hypertension develop microalbuminuria. Microalbuminuria, I will come again on the microalbuminuria, is a mild increase in the protein in the urine. Uh, this slide shows that the rise in as the blood pressure rises, the age adjusted ESID rates per 100,000 person years increases. The even modest elevation in the blood pressure is an independent risk factor for ESRD. You can see from that x-axis the blood pressure is increasing, and so as the blood pressure in x-axis is increasing, the ESRD rates are also increasing. So the higher the blood pressure, higher the incidence of the ESRD. This slide also shows you one more thing, that the white people are shown in the say black columns, and black people are shown in the white columns. So as in the incidence of ESRD is much higher in black people. So this is also the nephropathy has a more predilection in the African American people. Now the albuminuria. This is a protein. As the blood pressure in few of the patients with the rise in the blood pressure, these people start excreting protein in the urine, and when there is a mild increase in the protein in the urine, that is known as microalbuminuria. Microalbuminuria is an early marker of hypertensive renal disease. The microalbuminuria is defined as urinary albumin excretion from 30 to 300 milligram per day. 30 to 300 milligram per day. This microalbumin cannot be detected by the dipstick test. So when we use dipstick test, which shows 1 plus, 2 plus, 3 plus, this will be silent in that. Okay. Increase in microalbumin over time is a marker of worsening of endothelial function, which is associated with the worsening of kidney function. The proteinuria is defined as more than this is known as a proteinuria, and proteinuria is defined as protein excretion rate more than 300 milligram per day. The magnitude of proteinuria is directly associated with the progression of ESRD. Reduction in proteinuria delays the disease progression. So the strategy that lowers both the proteinuria and the blood pressure should maximally reduce the progression of nephropathy. This is a cartoon which again shows the interaction of blood pressure with interaction of blood pressure and proteinuria with the relative risk of the kidney disease. So on the y-axis again we have increasing blood pressures. On the y-axis we have the relative risk of kidney disease. On x-axis we have the increasing blood pressure, and these white dots are proteinuria which is less than 1 gram, and black dots are proteinuria more than 1 gram. And we can see in this area, one is that as the blood pressure has increased, there is a relative increase in the risk of the kidney disease. But if there is increase in proteinuria, increase in blood pressure, the risk of the kidney disease is much higher. So presence of proteinuria, presence of hypertension, both together leads to the increase in the relative risk of the kidney disease. So we comes to the now pathology of hypertension related to kidney disease. Is it a distinct pathology, or is it similar as which we see in a glomerulonephritis? No, the hypertensive kidney diseases, there is a distinct pathology, and it mainly involves small vessel disease, what we call as arteriosclerosis, and it involves the pre-glomerular vessels of the kidney, and the findings are in the vessels, in the arterioles. The findings are medial hypertrophy of the interlobular and arcuate arteries that may progress to medial fibrosis and associated with the new intimal hyperplasia. The afferent arteriole shows thickening and hyalinosis of the subendothelial area, which subendothelial area. The lumen diameter of arteriole is reduced, causing glomerular ischemia and focal and glomerular sclerosis. This glomeruli shows evidence of ischemia with collapse of glomerular tuft and eventually obsolescence. A subset of the patient with essential hypertension have a enlarged glomeruli with a segmental scars resembling focal glomerular sclerosis. This term has been used, a decompensated glomerular sclerosis, in a patients who have a presentation as a focal segmental glomerular sclerosis. This is what we call IFTA is basically interstitial fibrosis and tubular atrophy, which also shows the progression of the chronic kidney disease. If the patient has got a malignant hypertension, the vascular lesion shows a severe concentric hypertrophy, onion skin appearance, and fibrillar necrosis. I will just show you the presence of this arterial nephrosclerosis, and you can see this is a glomerulus, and this is the afferent arteriole, and you can see there is the lumen of the afferent arteriole is narrow. There is arterial hyalinosis is there, and there is medial thickening is there, and there is ischemic glomeruli are there. Ischemic glomerular tuft is there, and then there is a collapse of glomerular tuft. So this is what it looks like in a hypertensive nephrosclerosis. And next slide shows the diagram of the afferent arteriole, in which this is afferent arteriole. There is a thickening of the intima. There is thickening of media in the afferent arteriole, which is very classical of the hypertensive nephrosclerosis. So many patients have got essential hypertension, but not all tend to develop hypertensive nephrosclerosis. So there has to be additional risk factors which leads to the development of the hypertensive nephropathy. So what are the risk factors that favor the increase in the renal disease progression? One is the severe hypertension. So systolic blood pressure more than 170. So those people who have a severe hypertension with the blood pressure of 170, they are prone for hypertensive nephrosclerosis. Then long duration of hypertension may not be, not it is like 5 years, maybe 10 years, 20 years of hypertension that will lead to the hypertensive nephrosclerosis. Then as I showed you in the graph, African American race is very prone for hypertensive nephrosclerosis. That may be because of their socioeconomic thing, but may be related to genetics. Recently, risk genes, the genes have been found out in the African American. One is this MYH9, which is a known muscle myosin heavy chain 9 gene, and the other is a apolipoprotein 1 gene. There is a risk variant in this, and these people are very much prone for the developing of hypertensive nephropathy. Then presence of high uric acid, lead intoxication, and as discussed earlier, obesity, metabolic syndrome, diuretic use, and reduced nephron number. There is a concept that those people who have a decrease in nephron number be because of the, say, nephrectomy, because of some partial nephrectomy or kidney donation, or at times the reduced nephron number is also because of the premature birth. These people are more prone for the hypertensive nephropathy. And then with advancing age, nephron number also comes down, and these people are also prone for the hypertensive nephropathy. So does the control of the blood pressure decrease the progression of renal failure? There have been various studies. I am showing you graph for the one study only. the cumulative probability of ESRD in patient assigned for the usual blood pressure in which mean arterial blood pressure was 107 and other was mean arterial blood pressure which was low is 92. This study is known as MDRD study. The first 4 years, you can see there was no change in the kidney probability of kidney failure. But for the long follow-up for 10 years, we can see that there was more probability of kidney failure in a higher blood pressure group as compared to the lower blood pressure group, and hazard ratio was 0.66. So that means that over long term, the kidney function is it becomes better in people who have a well controlled blood pressure. This is another graph which is showing the same thing, that the higher blood pressure leads to high blood pressure. People who they have a faster decline in GFR, and if the blood pressure is a range of 130 to 134 systolic, then the GFR decline is much less. You can see the slope of this line versus slope of this line. So if systolic blood pressure is in range of 130 to 134, the GFR decline is much less as compared to when the blood pressure remains more than 140. So these are the goals. The blood pressure goals are there. Has been defined. Goal of blood pressure is usually there have been debate on the goals. I will be coming to that also, but most accepted goal for the control of blood pressure in for the chronic kidney disease is keeping the target of blood pressure less than 130 by 80. Less than 130 by 80. Even with good control of blood pressure, many patients continue to have a progressive nephropathy. One of the explanation could be that the office blood pressure is not able to capture the nocturnal hypertension or a mask hypertension. Hence, there is a role of 24-hour ambulatory blood pressure monitoring to confirm adequate BP control over a 24-hour period. These are the various international guidelines which have given the recommendation on at what is the goal of blood pressure should be kept, and you can see there is a slight difference in each guideline. Obviously these guidelines are depend upon the literature, and each one has interpreted the literature a little differently. This first is the actually American College of Cardiology and American Heart Association, which shows that blood pressure should be 130 by 80 or less than 130 by 80. The second is a European, and they have said that the systolic blood pressure should be in range of 130 to 139. Then this is UK guidelines, which is also shows the same the blood pressure should be 140 by 90, and this recently KDIGO recently has come out with that the systolic blood pressure should be less than 120. There are a lot of controversy about it, but this is the latest one which has come, and KDIGO is related to kidney. This is so there's a lot of controversy about it, and next slide will show that controversies. They have recommended that the blood pressure should be less than 120 systolic. So this is it. The KDIGO, there are many issues with it. First of all, they have used standardized BP, not a routine office BP. The standardized BP means that the person has to come, sit for 5 minutes in the chair, relax, and then take the blood pressure. There are 3 readings has to be taken, and the average of the 3 readings. Person should not have taken coffee, must have passed urine, bladder must not be full. There are many restrictions are there. In a busy OPD, this is very difficult. The average time which will be taken will be around 7 to 10 minutes to take the standardized BP. which obviously physicians or the nurses will not have. So this is not a routine office BP, and obviously for a practical consideration, we need a guidelines which have a routine office BP measurement. Secondly, there has been that such a low blood pressure like 120 systolic in elderly people who are very frail. There is increase in adverse event like increased postural hypertension, recurrent falls, fracture, acute kidney injury. They may develop stroke because they may have carotid artery stenosis, and they may be rapid decline in GFR because the perfusion pressure in kidney declines. Then, as I showed you, this recommendation is outlier. Most of studies on which it was dependent, they have excluded diabetes and significant proteinuria. So there are many caveats in the following the KDIGO systolic blood pressure. Most people tend to follow have a goal of a blood pressure 130 to 80, 130 systolic, 80 diastolic. So now we come to the management strategies to maximally reduce albuminuria, control blood pressure, delay the progression of hypertension in nephropathy are required. Most commonly, the rational use of blockers of renin-angiotensin aldosterone system and achieving blood pressure target are crucial to reduce the cardiovascular and renal outcomes. Okay, so first drug which is commonly used is our ACE inhibitors or ARB. ACE inhibitor means enalapril, lisinopril, ARBs, telmisartan, olmesartan, losartan. These are the first line treatment of hypertension with proteinuria. With use of this drug, there is a slight increase in the serum creatinine. But a rise of serum creatinine less than 35% within first 4 months of starting this drug is actually shows that these drugs are working and they correlate with the preservation of kidney function. So we should not be worried that, okay, we started the drug and the slight increase in creatinine has happened from 1.2 to 1.3, 1.4, acceptable. Anything so acceptable. So, but that is because that shows that in long run the kidney function will be preserved. But for acute increase in serum creatinine more than 40%, the patient should be evaluated for volume loss, congestive heart failure, and bilateral renal artery stenosis. One of the common side effect of ACE in ARB is hyperkalemia, and as you are learned from the previous slides, the hyperkalemia is very common in chronic kidney disease. So so we should be very vigilant. Hyperkalemia should be managed with avoidance of high potassium food, diuretics, and stopping agents known to increase potassium such as NSAIDs. This is again a same cartoon which shows the same thing. Once we initiate ACE inhibitors or ARB, we must monitor serum creatinine and potassium every 2 to 4 weeks. The second line of drug is a calcium channel blocker. But both dihydropyridine and non-dihydropyridine calcium channels are effective. But in those patients who have significant proteinuria, non-dihydropyridine like verapamil, diltiazem, they are more effective as compared to amlodipine, nifedipine. Beta blockers are also useful in controlling the blood pressure in chronic kidney disease. Carvedilol, which is a combined alpha and beta blocker, tend to reduce the cardiovascular morbidity, mortality, and it has also been shown to decrease the microalbuminuria development because of the antioxidant properties. The aldosterone antagonist, the spironolactone, is recently been added to our armamentarium, and it is a fourth line therapy for reduction of blood pressure, and addition of this usually lead to reduction of blood pressure by around 20 by 10. It also tend to reduce proteinuria, but it tend to cause hyperkalemia. So using ACE inhibitors, using spironolactone, and in CKD patient, chance of hyperkalemia is too much, but we need to be vigilant. And if the patient does not develop hyperkalemia, we can use it. Diuretics, chlorthalidone is preferred over hydrochlorothiazide. In patients who are on furosemide and there is furosemide resistant, adding furosemide with amiloride leads to a good result. There are other antihypertensive agents which can be used to control the blood pressure. They have not shown to decrease the progression of renal disease, but blood pressure needs to be controlled. One is a central alpha-2 agonist, clonidine, which comes by name of arcamine. Alpha-1 blocker, doxorubicin, prazosin, then methyl dopa, peripheral vasodilator, hydralazine, minoxidil. These are the few antihypertensive agents which to be used to control the blood pressure. I think there are few last slides. The anti-diabetic drug few anti-diabetic drugs have also shown to decrease the blood pressure, and they are renoprotective. The one is that recently introduced drug, sodium glucose co-transport inhibitor. The dapagliflozin has been shown to reduce blood pressure by 5 millimeter mercury. The KDIGO has recommended that it should be used as a first-line drug in diabetic kidney disease. In a non-diabetic patient also, dapagliflozin has been shown to decrease the cardiovascular outcome and decrease the progression of chronic kidney disease. Is a non-diabetic patient also. So it is a drug which can be used in a non-diabetic chronic kidney disease. Then there is the endothelial receptor A antagonist. They have been also shown to decrease the blood pressure. Atrasentan, which is a endothelial receptor A antagonist, has been shown to decrease albuminuria in diabetic nephropathy, also tend to decrease the blood pressure decrease the doubling of serum creatinine or ESRD when used. And I think the lifestyle modification everyone has talked about, non-pharmacological intervention, weight reduction, limiting salt intake, and exercise, weekly exercise, 150 minutes per week exercise. So that's what it is recommended. So this is an algorithm to add the blood pressure medications. Basically, it shows that if the blood pressure is less than is from your target, it is only 20 millimeter mercury increase, then add only one drug, ACE or ARB. If it is more than 20 millimeter mercury increase from your target, then add two drugs, and then every 3 weeks you keep checking and keep adding more medications, increasing the doses. Again, same thing. What are the first line drugs? Same ACE inhibitors, ARB are the first line drug. Calcium channel blockers are second line drug. Then diuretics, and then aldosterone antagonist. So the take home message: the cornerstone of effective therapeutic strategy to slow the decline in renal function due to hypertension include adequate 24-hour blood pressure control, reduction in albuminuria from albuminuria, then use of ACE inhibitors and ARBs, sufficient antihypertensive medication at maximally tolerated dose so that to decrease the systolic blood pressure less than 130, restrict sodium intake to around 2 grams per day. And as discussed, physician-patient communication and education to improve adherence to the recommended therapy. Also, there is the physician inertia must be overcome, and better to use a fixed dose combination that will increase compliance. Thank you.
Questions from the audience? Then thank you so much, sir, on highlighting the hypertensive nephropathy, which is the second leading cause of end-stage renal disease. So, sir has focused on how hypertension can cause a renal disease, and also he has shared the various contemporary major international guidelines, which says that how much the optimum level of blood pressure which should be there, which we need to control as a physician. He has also emphasized on various medications, antihypertensive, which are safe to use, and if not safe, then what kind of other precautions we need to take side by side by monitoring the patient. And also he has also enlightened us with the various lifestyle modification along with the medication, how we are able to control hypertension. Thank you so much, sir, for your enriching session. Now I would like to invite Dr. Pragya Pathak to please uh, kindly give a token of love from our side to sir.
Wait for lunch with us. We'll just take 5 minutes. So, so we'll display the posters. We have completed the poster competition. We'll display the posters here. And till then, till the judge will show you a Nukkad Natak performed by our students on a recording. Nukkad Natak video. We'll be announcing the winners of the poster competition very soon. Your email IDs with the organizer so that we mail you the certificates. Or otherwise, mail at Kidney Day mail ID so that we will be able to send you the certificates. And still, if anyone faces any problem in getting or generating the certificate, please mail it on the Kidney Day mail ID. It is open for next 7 days. Till then, we'll entertain you for the certificates.
The results of the poster competition have also come out. Starting from the third prize, it goes to participant number 5, Anandi. I think we should appreciate her more because she joined at 11 o'clock and with great difficulty she managed to finish. Please come. I invite the judges, Madam Gulati and Madam Nasreen, to please come and felicitate our winners. Our second prize goes to participant number 2, Gayatri. And finally, the first prize goes to participant number 4, Surya Prakash.
Please come forward once again.
Thank you, judges, and thank you all the participants for all your contribution.
Thank you everyone and congratulations to the winners. And now I request Dr. Pragya Pathak to deliver a vote of thanks.
So it gives me immense pleasure to propose vote of thanks on behalf of the chairperson, coordinator and organizing team of the today's World Kidney Day program. I would like to express my sincere thanks to our most distinguished chief guest of the day, Dr. Professor Randeep Guleria sir, Director AIIMS, for gracing this occasion with his esteemed presence and always supporting us. I would also like to express my profound gratitude to esteemed guest Dr. S.K. Agrawal, Head Department of Nephrology AIIMS, for his constant support and words of wisdom. I extend my sincere gratitude to Dr. Lata Venkateshan, Principal College of Nursing, for her unconditional support, encouragement, and guidance in conducting this program. I would like to thank Dr. Shashi Mawar, coordinator of today's program, for her constant support in organizing this program, coordinating the event, and arranging with all the logistics for conducting this program. I thank the organizing team of Faculty of College of Nursing, Ms. Aditi and Ms. Anubha, for organizing this event. Their constant tireless efforts have been there for the past few days, and they arranged the program in short span of time. My note of gratitude and thanks to all the speakers across the globe who were there in the program, and they shared their words of wisdom. I express my thanks and gratitude to the judges present here, Dr. Seema Gulati and Dr. Nasreen Akhtar, who judged the poster competition event. I express my thanks to all the participants who have been there online and offline. Because of you, this event has been successful. I would like to thank our MSc nursing students, Mr. Navid, Arya, Harpreet, and Pooja, who tirelessly effort day and night to make this program a success. I would also like to thank our BSc nursing students who have performed Nukkad Natak to educate the public. We are very thankful to them. I'm thankful to the staff of the CMET set facility, especially Mr. Susan, who have been there since morning with us, and they have arranged with all, provided with all the technical support. I thank all the staff from the College of Nursing also for supporting us. I thank all the faculty from the College of Nursing and Department of Nephrology for their constant support and encouraging us to conduct this program. I would also like to thank the AIIMS cafeteria for providing us with the refreshment and lunch. I thank once and all who have worked behind the scenes also, and I may have missed out some of the names. So sorry for that, and I thank everyone, each of you, from the bottom of my heart. So have a wonderful day. Thank you all. So all of you can please come for lunch.